Good afternoon. I would like to welcome you to the Enforcement Committee session of the Medical Board of California. Today, July 27, 2017, and the time is 1:12 p.m. I'm Dr. Felix Yip, Chair of this committee. I want to ask all of us to please turn our cell phones to silent. You may notice committee members accessing laptops during the meeting. They are using the laptop solely to access the committee meeting material that are in electronic format. This is an official business meeting of the Medical Board of California, and as such, disruption of the committee's business will not be tolerated. We have a designated time on the agenda for public comment, and we will be asking for public comment on each agenda item. I ask that you be respectful of the need to conduct the committee's business. Should anyone disrupt the meeting, I will ask the person to conduct him or herself in such a manner that permits the committee to transact the business. The committee welcomes public comment on an item on the agenda, and it is the committee's intent to ask for public comments prior to the committee taking action on any agenda item. If for some reason I forget to ask for public comment on an agenda item, and you wish to speak on that item, please raise your hand or come forward and you'll be recognized. I would like to request all speakers complete a presenter slip so I can call you by name at the appropriate time, and the record of this meeting can be full and complete. However, this is voluntary. Please give the speaker slip to Ms. Tuve. Ms. Tuve, please identify yourself for the audience. This meeting will be available via teleconference. Individuals listening to the meeting will have an opportunity to provide public comment and will be assisted by a moderator who will be facilitating the teleconferencing process. For those members of the public participating via teleconference, please wait until the moderator has introduced you before you make your comments. To request to make a comment during the public comment period, press star 1. You will hear a tone indicating you are in queue for comment. If you change your mind and do not want to make a comment, press the pound sign. Please remember to mute the volume on the screen to avoid feedback. Assistance available throughout the teleconference meeting. To request a specialist, press star 0. Each person will be limited to 3 minutes per agenda item. However, during agenda item 2, public comments on items not on the agenda, the committee has limited the public comment period for individuals on the teleconference and those present here today to 20 minutes. Therefore, after 20 minutes, no further comments will be accepted. During public comment on any other agenda item, 10 minutes will be allowed for comments from individuals on the teleconference line and those in the audience. After 10 minutes, no further comments will be accepted. Staff from the Board's Business Service Office will be assisting me with receiving the public comments via teleconference during this meeting. I want to remind all speakers to please stay on topic and keep your comment to 3 minutes or less. I would like to call this meeting to order and have Ms. Tu please call the roll.
Dr. Bolott? Present. Judge Feinstein? Present. Dr. Levine?
Present.
Dr. Lewis?
Present.
Ms. Wright?
Here.
Dr. Yip?
Here.
We have a quorum.
Thank you. A quorum is present. I would like to remind the members that we will be taking a roll call vote on all action items. Moving the agenda item number 2, public comments on items not on the agenda. I don't see any speaker slips. Are there any comments on the phone?
Catherine, do we have any comments on the line?
No questions in queue at this time.
Let's move on to our next agenda item number 3, approve of minutes from the January 26, 2017 meeting.
I move to approve the minutes from the January 26, 2017 meeting.
Are there any public comments from those in the audience? Any comments from those on the phone? Ms. Tu, please call the roll. Oh, no comment? Great, thank you. Ms. Tu, please call the roll.
Dr. Bolott?
Present.
We're doing for agenda item 3.
Oh, I'm so sorry. Aye.
Okay. Judge Feinstein? Aye. Dr. Levine?
Aye.
Dr. Lewis?
Aye.
Ms. Wright?
Aye.
Dr. Yip.
Aye.
Thank you.
Minutes approved. We'll now move to agenda item number 4. Ms. Dell will provide an enforcement program update.
I don't know what's going on.
Okay. Good afternoon, members. On July 5th, an enforcement meeting was held to discuss case processing timeframes, what improvements have been implemented to decrease timeframes, and what additional measures can be taken to efficiently process the work being done by the Board, the Department of Consumer Affairs Health Quality Investigation Unit, and the Attorney General's Health Quality Enforcement Section. The participants at this meeting were myself, Enforcement Chair Dr. Yip, Executive Director Kim Kirchmeier, Program Managers Susan Houston and Paulette Romero, Chief David Chris and Deputy Chief Kathleen Nichols, Senior Assistant Attorney General Gloria Castro, and Supervising Deputy Attorney Generals Matt Davis and Terry Jones. The agenda was comprehensive and included an update regarding the change to the 805 peer review reporting process, a discussion about monitoring vertical enforcement investigations and post-accusation pleadings, a dialogue about the potential changes to the vertical enforcement process and how those changes would be implemented, the role of a probation inspector and what other functions could be transferred to them, a discussion about the changes HQIU has made to resolve its vacancy rates, and a review of enforcement statistics. Deputy Chief Nichols will discuss the efforts made by HQIU to resolve the vacancy issue during her presentation at this afternoon's board meeting. The improvements to the 805 peer review process are working well. The subpoena is usually drafted, executed, and served within 1 week to 10 days of the filing of the 805 report. This improvement began on April 24, 2017. 10 weeks to date, and 20 cases have been reviewed overall. 18 of the 805 reports reviewed statewide, 18 subpoenas were prepared, executed, and served. Compliance letters were sent to 3 facilities requiring a new 805 report to be completed and submitted within 5 business days. Reason being is the original 805 report lacks sufficient detail as required by law. A total of 4 cases reviewed for prosecution for notice of violation and imposition of fine for late 805 reports has also been reviewed. 2 have been declined and 2 are identified as probable for prosecution. A Deputy Attorney General has been assigned to assemble the cases for prosecution. And 5 cases have been identified as possible interim suspension orders. To ensure field investigations are moving along in a timely manner, the participants agreed a plan is needed to address case inactivity. If after 2 quarterly case reviews the case has not progressed, the lead prosecutor for the case will email HQIU executive management to address the issue. For example, if several attempts for certified medical records have been made and no other case activity is noted, the next step would be to issue a subpoena for the records. Or if a subpoena was issued and the subject did not comply with producing records or perhaps appearing for a subject interview, then the subpoena needs to be enforced. This is not to say that Health Quality Investigation Unit HQES is not doing these tasks, but with the high vacancy rate and volume of cases investigated and prosecuted, some activities might take longer than usual, and by taking a team approach to monitoring cases, overall case processing times will decrease. When a case is 6 months from the approaching statute of limitations, HQIU Commander and a Supervising Deputy Attorney General will agree on a plan to prioritize the case and finish the investigation where the statute of limitations occurs. The Board will revitalize the monitoring of its post-accusation report. This report shows which cases have been filed at the AG's office but are awaiting a hearing date. By following up with HQES, cases will get set for hearing, which will either lead to resolution through an administrative hearing or settlement of the case in a timely manner. Regarding probation, in some instances, probation will request the assistance of a HQIU investigator to gather evidence or interview the probationer when a violation of probation was believed to have occurred. However, probation staff will take the lead when gathering evidence needed to support a violation, and doing this, HQIU can focus on investigating open complaints. Overall, the meeting was very productive, and at the request of Dr. Yip, an enforcement meeting will occur every 6 months to confer on topics related to enforcement and conducting business in the most effective and efficient manner. At the conclusion of my update, perhaps Dr. Yip may like to share a few words about this meeting. On July 12th, staff from the Board's Probation Unit and staff from First Source Solutions, who is the Board's approved vendor to manage the biological fluid program, gave a presentation to all Deputy Attorney Generals from the Health Quality Enforcement Section. The presentation provided an overview of probation protocols and policies concerning biological fluid testing, the services First Source provides as the administrator of the BFT program, and an understanding of the different types of tests that are performed, which may be either hair, blood, or urine. Probation staff continues to take immediate action when a licensee has violated his or her probation. As of July 3rd, a total of 52 petitions to revoke probation and 8 accusations and petitions to revoke probation have been transmitted to the Attorney General's office during fiscal year 16-17, and the total number of cease practice orders issued is 35, which is a 150% increase from the previous fiscal year when 14 cease practice orders were issued. That concludes my enforcement update.
Dr. Levine.
Thank you so much. There's a lot of information in what you just conveyed to us, and I'm kind of a visual learner. It would be really helpful to see graphically that displayed what the process was and what changes resulted from the July 5th meeting so that we could try and understand what's going to happen that's different.
Okay.
It's just, for me, just hard to follow just purely auditorily.
Yeah, I also agree. I think in the past we've seen the visual comparisons from quarter to quarter, and if you next time we could see that, it just solidifies it a little better.
Okay.
For me.
Any public comments from those in the audience?
No questions in queue at this time.
Okay, quick. I was going to ask on the phone. So actually, it was a very productive, like a workshop meeting with 3 parties involved: the investigators, our enforcement unit, and also the Ms. Corey Castro that brought on 2 decks, all the way from LA, Sacramento, and I think Ms. Nichols and Mr. Chris are not here. They're also there together. All the stakeholders work together to see how, I like the term is that use case connectivity, that we're all on the same page, all connect how to shorten time frame. There's some issue about the vacancy rate with the investigator, which actually the staff and different officers address that, you will hear later how to recruit more non-sworn officers to help with that. It's true, I think there are a lot of statistics went through. I learned PM means performance measure. So we went through a lot of statistics. So it's a good idea next time we should show those on the graph so you can see the progress or difficulty we have. So, but I truly enjoyed the experience and really appreciate the compassionate effort for all parties who came to the table. So I suggest that at least we should do it twice a year, all 3 officers together to work on how do we case connectivity. So thank you, Ms. Dell. Moving to agenda item 5, Ms. Dell would now provide an update on the expert reviewers training and recruitment plan.
Since my last update given at the January board meeting, a total of 35 new experts have joined the program. 2 expert reviewer training sessions have been scheduled for this fall. One will be held in Sacramento on Thursday, September 28th, and the other will be held on November 2nd in Sylmar. To encourage attendance, a save-the-date announcement was emailed to board experts. The announcement has been added to the board's website located on the expert reviewer homepage, and registration for the 2 events is now open. Historically, expert reviewer training has been held on a Saturday. However, this time the board is conducting the training on a weekday to see if this will draw in more attendees. On average, 50 participants have attended a weekday training session. There are approximately 700 active experts in the program that have not attended a board's training. If the board does not see an increase in participation after the next 2 trainings, the program will send out a survey to active experts in hope of gathering information that will assist the board in boosting the attendance rate. Regarding the board's expert review recruitment plan, stage 2 of the plan was to be completed by spring of 2017. However, the program did not meet its goal by the estimated time frame. Stage 2 consists of placing advertisements about the program into external newsletters and magazines and giving presentations about the program at hospital staff meetings, CME events, and/or special conferences. Preliminary research has been done to obtain costs for placing advertisements into newsletters and magazines, and staff is exploring the possibility of attending 3 recruitment events in the LA area in September and October, and researching more events to attend by the end of 2017. As well, every time Ms. Kirchmeier speaks in front of a group of physicians, she asks for experts to join the program, and at a recent meeting, at least 3 individuals followed through with applying. The board's Information Systems branch developed a new expert reviewer database called the Consultant Expert Management Program, or CEMA. This program combines the Central Complaint Unit's Medical Consultant Database and the Expert Reviewer Database into one comprehensive system. Besides upgrading the old systems into a newer platform, this database has the capability of running management reports, thus eliminating the need to track cases on Excel spreadsheets. The board anticipates CEMA will be fully implemented mid-August. Lastly, program staff is working to create a midwife expert reviewer brochure similar to the expert reviewer brochure that was created and shown at the January board meeting, and staff is exploring the possibility of creating a biannual expert reviewer newsletter. The purpose of the newsletter is to provide information to experts about the program and tips for writing a good report. The program sees this tool as an opportunity to discuss facets of the expert reviewer manual in a format that highlights the components necessary to write a legally sound opinion. For example, the newsletter can showcase information about what are simple and extreme departures, an overview of enforcement functions and the expert's role in the process, and formatting tips to write a clear and succinct document. If any of the members from the board's enforcement committee are interested in adding an article to the newsletter, please let me know, as your input would be valuable to make the project a success. Thank you. That concludes my update.
Question. Hi, Christina. Can you tell us how short you are on expert reviewers and what category? We used to have a list where we would have the data and how many you needed.
It is,
in your opinion, what do
it
you
is
think?
in the your packet under
I can't find it in there.
20B.
20B.
Under the full board packet.
No, I couldn't find it. So I know it's there, but
Yeah, it's agenda 20B. So if you go to that, it does list in narrative form the experts where they're needed in the following specialties. And the 3 events that staff is going to hope to go to in September and October is focusing on at least 3 of those specialties. So we are reaching out and finding places that we can go and recruit in those areas.
And when you go out to the sites, the board members, we have an opportunity to accompany you if we're in the locale.
Absolutely.
Correct?
More than welcome. We will tell you.
Sometimes there's a sort of a personal communication from doctor to doctor, which sometimes has a little different effect. Not that you don't have an effect, but just sort of personalizing the program.
Mm-hmm.
So please, again, reach out to us.
Yes, very good. We will definitely send all of you on the committee the dates and to who would be able to go.
If we're local, I know budgets are tight, but if we're local, I would come and speak or be a presence. So,
okay.
Thank you.
Any other questions from members? Are there any public comments from those in the audience?
We have no questions in queue at this time.
Thank you. Really moving along. To agenda item 6, Ms. Henderson will now give a presentation on the Complaint Investigation Office. Dr. Levine, you want to move over there?
I will. Thank you.
Yes, Ms. Kirkman.
I'm sorry, I should have written this into, made sure it was in your script. I just want to actually introduce Roshaya, or Miss Henderson. Roshaya Henderson is actually our Complaint Investigative Unit office manager, and I just want to say that Miss Henderson has done a yeoman's job. I don't know, you won't know this from her presentation, but starting in July 1st of 2014 when the unit started, she stepped in and took this program from being nothing all the way to what she's going to tell you that it is. And so I just wanted to introduce her to you. This is the first time I believe you've been before the board. And just say that all of the work of this program really has been because of her training. She's trained individuals. She's provided training for other individuals as well outside of her own unit. And all that you're seeing is basically her building this from the ground up. So I want to introduce her.
Thank you.
Thank
Welcome
you.
too.
Thank you. As Ms. Kirkmeyer just stated, my name is Rashaya Henderson. I'm the Supervising Special Investigator of the Complaint Investigation Office, also known as CIO. The history of the CIO was established in July of 2014. At the same time, the Medical Board's sworn investigators moved to the Department of Consumer Affairs Division of Investigation, Health Quality Investigation Unit due to Senate Bill 304. I should also note that the positions for CIO are positions under the Consumer Protection Enforcement Initiative, so that's where the positions originated from. CIO was created to handle less complex investigations and to reduce the caseload referred to the sworn investigators at D of I. Staffing consists of myself, one supervising special investigator, non-sworn, and 6 non-sworn special investigators. What do we do? The Complaint Investigation Office investigates the following case types: criminal arrest or convictions. And those cases are typically referred to us via DOJ. The Department of Justice will send out a subsequent arrest notification for any of our licensees that have had contact with law enforcement. The Medical Board may also receive criminal arrest or conviction cases from a self-report from a licensee. Under BMP, the Business and Profession Code 802.1, there's a mandatory reporting requirement for licensees if they have been arrested for a felony or indicted on a felony and or a misdemeanor conviction. They must be reported to the board within 30 days of occurrence. The Medical Board also receives information on criminal or conviction cases from the court clerk. There's a reporting requirement for a court clerk under BMP Code 803. And that is if a licensee has committed a crime or is liable for any death or personal injury resulting in a judgment of any amount caused by his or her negligence, error, or omission in practice, or rendering unauthorized professional services, the court clerk must report that information to the Medical Board within 10 days after judgment. There can also be a report from the court clerk pursuant to 803.6a in the event a felony preliminary hearing has occurred. The transcripts from that hearing are supposed to be provided to the Medical Board where the length of the transcript is under 800 pages, and if it is more than that, then we are simply just notified that there is a transcript available. Another way we receive notice of criminal arrest or conviction cases would be through news articles and or complaints from the public. The next case type that the Complaint Investigation Office works would be medical malpractice, and those cases are pursuant to BMP Code 801. Those are mandated reports of settlement, judgment, or award over $30,000. The next case type that CIO works would be petitions for reinstatement of a revoked or surrendered certificate, and BMP Code Section 2307 allows for the petition for return of a revoked or surrendered license. Part of the requirements under BMP 2307 is that there's a 3-year waiting period for reinstatement. And also those petitions must be accompanied by 2 verified letters of recommendation from other licensed MDs who have personal knowledge of the petitioner's activities since they were disciplined. The last case and fairly new case type that the Complaint Investigation Office is working are medical exemption or vaccination exemption cases. This is a new small workload due to new legislation, SB 277, which eliminated the personal belief exemption from existing immunization requirements. A medical exemption letter has to be issued by a licensed physician if he or she determines that vaccination is not safe for the patient, dependent on the patient's medical condition, history, and family medical history. The medical board receives complaints alleging physicians are failing to issue medical exemptions, as well as complaints that inappropriate medical exemptions are being issued by physicians. A little background or further information on how we conduct our investigations. The investigators under CIO will gather evidence, including interviewing the subject, interviewing witnesses, acquisition of physical evidence such as arrest reports, court documents, medical records, fetal monitoring strips, x-rays, etc. If needed, a case such as a medical malpractice 801 case would be sent to an expert to render a thorough, unbiased medical opinion as to whether the standard of care was met. The Complaint Investigation Office follows the same investigative process as the sworn investigators with HQIU. Recently, on November 2nd of 2016, all CIO staff attended a one-day training in conjunction with HQIU and the Attorney General's Office on subject interviews and how to appropriately conduct those. When a case goes out to expert review, the experts are given 30 days to render an opinion on if there's been a departure from the standard of care, and if there has been a departure, the severity of that. And CIO utilizes the same experts as HQIU. Now a little bit of comparison between CIO and D of I HQIU. CIO does not work under the vertical enforcement model. We work up cases independently. However, if we have a legal question, we will refer that to the AG's office, the AGO. The AG's office is also responsible for reviewing all case closures and all 801 cases. Those would be the medical malpractice that are referred for further investigation. If it's determined that a violation of the Medical Practice Act has occurred, the Complaint Investigation Office will prepare a transmittal memo and package up the case for referral to the Attorney General's office that corresponds with the area that the case was from. CIO works cases statewide, where D of I has offices in certain areas to handle the caseload for that specific area. So CIO is located at MBC headquarters. Let's see. CIO cannot perform the following duties due to the fact that they are not sworn law enforcement. We cannot perform pharmacy audits. And that is pursuant to BMP Code 4017. Pharmacy audits can only be performed by authorized officers of the law, and that is defined as Board of Pharmacy Inspectors, Department of Health Service, Food and Drug Branch Inspectors, investigators from D of I, or peace officers engaged in official investigation. CIO does not execute undercover investigations. We simply do not have the equipment to perform those, and there is a lot of coordinating between local law enforcement in order to conduct an undercover operation, which we simply don't have the resources for that at this point. We do not issue misdemeanor citations. Once again, we're not law enforcement. We also do not serve search warrants or execute arrests because, of course, you would need to be law enforcement to do those. In the event CIO has a case in need of any of the above noted tasks, we'll refer the case to HQIU for further assistance and or further investigation by that D of I office. Some statistics on CIO. As Ms. Kirkmeyer stated, we were established in fiscal year 14-15. So the graph to the left will show case closures. In our first year, we closed about 309 cases. In fiscal year 15-16, we closed 391 cases. And for the current fiscal year 16-17, which I'd like to note that the stats for this fiscal year 16-17 only include the first 3 quarters of the fiscal year. So as of the first 3 quarters, we've closed 299 cases. For case transmittals, the chart to the right, for our first year, fiscal year 14-15, we transmitted 20 cases. For fiscal year 15-16, we transmitted 92 cases, and for the first 3 quarters of fiscal year 16-17, we have transmitted 41 cases. The average caseload right now in the Complaint Investigation Office is about 50 cases per special investigator. And I'd like to note that case closures increased by 26.5% between fiscal year 14-15 and 15-16. With regards to case transmittals, they almost quadrupled between fiscal year 14-15 and 15-16. In fiscal year 15-16, CIO was tasked with assisting probation with processing petitions for early termination of probation, which resulted in an increase in the number of transmittals. I anticipate a slight decrease in the number of transmittals for fiscal year 16-17 as we are no longer assisting probation with the early termination of probation cases. Some changes to CIO since establishment. In November of 2015, CIO began issuing subpoenas for certified medical records, arrest reports, and other various documents. Prior to that, CIO had been requesting assistance from D of I HQIU when a subpoena was necessary to obtain documents. And the reason for that was when the sworn investigators moved under D of I HQIU, NBC's enforcement program temporarily lost subpoena authority. Currently, we have 3 individuals with delegation of authority to sign subpoenas at the medical board. In March 2017, CIO began processing 820 mental or physical examinations as part of the investigative process, and 820 is referring to the BMP code, which gives us authority to request those. Section 820 reads that whenever it appears that a person holding a license, certificate, or permit under this division or any act referred to in this division may be unable to practice his or her profession safely because the licensee's ability is impaired due to mental illness or physical illness affecting competency, the licensing agency may order the licensee to be examined by one or more physicians or psychologists designated by the agency. The report of the examiner shall be made available to the licensee and may be received as direct evidence in proceedings conducted pursuant to Section 822. In processing the criminal conviction cases, it was determined that some cases may require a mental or physical exam pursuant to BMP Code 820 to ensure that a physician and surgeon is safe to practice. Initially, CIO was sending cases in need of an 820 evaluation out to HQIU for processing. However, after speaking with upper management and seeing an uptick in the need for 820 evaluations, the decision was made to have the Attorney General's office provide CIO staff with training on how to process 820 evaluations so we could start with that caseload. CIO received training from the AG's office on March 3rd of 2017, and we have been actively working cases that have a need for an 820 exam. As stated earlier, on occasion, CIO assists the probation unit with processing petitions for early termination of probation. And in fiscal year 15-16, CIO processed 34 early termination of probation cases. Some other tasks for CIO. We may be assigned special projects, and that could include processing cases referred from the licensing unit. When the licensing unit identifies an issue with a licensee after a license has already been issued, the case may be referred to CIO for further investigation. And an example of this would be licensing referred 2 cases early on when CIO was established after learning that the licensees used their Canadian social insurance number and not a United States social security number on their online application for licensure. Another special project or assignment for CIO is assisting the Discipline Coordination Unit, also known as DCU, in locating licensees when in need of serving disciplinary documents. CIO has access to run LexisNexis and or DMV requests to locate the most recent address for licensees when DCU has been unable to contact or locate when they're attempting to serve disciplinary documents. Another special project would be obtaining certified court documents for out-of-state discipline cases forwarded to the Attorney General's office based off a criminal conviction. CIO requests certified court documents for those out-of-state cases because we are one of the few units that has an evidence fund in order to pay for those documents. Unfortunately, we are not provided documents at no cost anymore, so there's usually a fee associated with obtaining those certified criminal documents to support the out-of-state discipline if it was based off a criminal case. That concludes my presentation on CIO. Are there any questions from the board members?
Thank you. Dr. Levine?
Thank you. That was great. One thing that would be helpful on your third slide, where under the what do we do?
Yes.
Slide. It would be helpful over time for the board to be able to track the number of cases in each of those categories to understand the nature of complaints, accusations, etc., convictions, and whether, what direction it's moving in. And in particular, I have an interest under the vaccination exemptions, tracking by how many of those complaints that you receive are about failure to issue a certificate versus the inappropriate issuance of a certificate. So breaking it down that way, it'd just be, maybe twice a year being able to see the kinds of things you're dealing with.
Okay. Well, to answer your question with regards to the vaccination exemption, right now primarily the cases we're seeing are inappropriate exemptions being provided to patients. I feel like those are the majority versus a physician not providing one where it is needed.
Are they coming from schools or?
We are receiving complaints from schools, from other physicians. Some come from parents when there's a child custody issue where one parent may want the exemption, one parent may not want the exemption. So those are the three primary sources.
Any other questions? Who signed off those case closed and case transmittal, like Ms. Delp or Ms. Kurtmeyer?
I review all of the cases, and case closures are reviewed and transmittals are not reviewed by Ms. Delp or Ms. Kirkmeyer. I am responsible for reviewing all of those. Like I said, anytime a case is closed, it's reviewed by the Attorney General's office to make sure there isn't anything we missed or there's not a need for any further investigation. Because we don't work under VE when a case needs to be transmitted, we will package the case up for transmittal to the SDAG in the area the case would be assigned to. And typically our cases are accepted. I think we've had maybe 2 or 3 cases that have been rejected by the AG's office. But if there are any questions, the AG's office will follow up with myself and the investigator that was assigned to answer any questions or provide any supplemental investigation that's needed.
Great, thank you.
Thank you.
Any public comments from those in the audience?
We have no questions at this time.
Thank you. Moving agenda item 7, Ms. Kurtmeyer will provide an update on opioid-related death certificate information from the California Department of Public Health.
Good afternoon, members. This is actually a project I'm really happy to actually provide an update on. It's one that's been being worked on for a couple years now, and now we're to the point where actually the information that we're giving you is actually going to be useful for you to understand kind of what we've been doing for the last several years. So I think you'll appreciate this, especially in view of the opioid epidemic that's going on right now in the country. So as some of you may remember, in 2014, then Senator Price, who was also the chair of the Senate Business and Professions Committee, introduced Senate Bill 62, which would have required coroners to report deaths when the cause of death is the result of prescription drug use. This report would have contained identifying information so the board could perform an investigation to determine if a physician was inappropriately prescribing. Currently, the law requires a coroner to report to the board when he or she receives information based upon the findings by a pathologist indicating that a death may be the result of a physician's gross negligence or incompetence. Over the last 2 years, the board has received 9 complaints from a coroner's office. Senator Price thought that if the coroner didn't have to make that determination that a physician was grossly negligent or incompetent and that the death was just related to prescription drugs, it would improve the reporting to the board and also help identify physicians not following the standard of care. Due to the fact this bill would impose an unfunded mandate, the bill was actually vetoed. After the veto of this bill, Staff spoke with Senate Business and Professions Committee staff about this bill and a possible solution. After these discussions, board staff thought it may be able to find another path to this information. This is based upon a recommendation from actually the Business and Professions staff too. We contacted the California Department of Public Health, who collects all death certificate information. After several months, actually probably almost a year and meetings, the board signed an interagency agreement with CDPH to obtain information on deaths related to opioid prescription drugs in year 2012 and 2013. This data set used codes that CDPH used to identify the underlying cause of death and the contributing cause of death in order to identify opioid pharmaceutical related deaths. In August of 2015, the board received the information for both of these years. Once the data file was received, the board used the CARES database to determine who was prescribing to the individuals and also looked at the prescribing practices of the attending physician or the physician who certified the death. Once CARES information was obtained, the reports were sent to experts who reviewed the data to determine if it appeared that there may be inappropriate prescribing. The board has one person who has been assigned to this task, so she's been working all of these cases as they've gone through the whole process. All of the reports have now been reviewed, and the board is working to initiate all of the cases and either begin the process in the central complaint unit by obtaining the medical records or sending these cases to the field for investigation directly. Here are the statistics from the information that we received. So for the 2 years, 2,692 individuals' deaths fell into the categories we identified related to prescription drugs. Of those, 2,256 had a CARES report that needed to be reviewed by a medical expert. After review, the board identified 522 cases that needed to be initiated to investigate the physician who may be inappropriately prescribing. The board at this stage is writing letters to request authorization to review the medical records. And some of the cases have actually even moved through that process farther than that too. This has been an extensive project and one that still needs a lot of work to complete. However, this has been invaluable in the board's role of consumer protection and the board's goal of finding proactive ways to investigate, as Dr. Levine knows well aware about the proactive complaints. The board has received very positive feedback from the experts who have been reviewing these cases. One expert stated that although our initiation process for these cases has been extremely time-consuming, it is worth the effort. Another expert stated the systematic approach of this project has given the board a chance to discover who the overprescribers are rather than having to wait for specific complaints to come in. This project has been crucial in discovering these providers and protecting vulnerable consumers struggling with addiction. One expert actually identified some notable findings in all the cases they reviewed, which I actually find very interesting. The expert stated that there was a group of patients who died from an overdose unrelated to the prescription drugs they were receiving from their physician, revealing the use of either diverted or illicit drugs. Another group of patients received controlled substances from a large number of prescribers, and it is unclear whether any of these providers were actually aware that their patients were using multiple prescribers. And then there was, of course, the group of patients whose death is closely linked to the prescribing habits of their primary provider, which was quite common. In general, the provider was writing for high-dose opioids in combination with one or more sedating drugs like benzodiazepines, soma, and sleeping pills. The expert went on to state that this is probably the most important lesson from the work, the specific links of deaths related to the known risks associated with high-dose opioids greater than 80 MEDs per day, particularly when linked with the concurrent use of other sedating medications. Finally, in reviewing the CARES report on these providers, it was common to see many other patients receiving the same combinations and at risk for harm. So basically, when they would review the information on that provider, they would see the name of the individual. Obviously, they were looking at that one, the one that had died, that caused us to pull the record on that individual. But then when they started looking, they saw all of these other patients also who had been possibly inappropriately prescribed to. The expert recommended that the board most definitely continue to obtain this information from CDPH every year, and the board will be doing that. This has been a project which we have found invaluable, and we wanted to provide the board with this update. So are there any questions with that?
Yes, hi, thank you for that. That is really most interesting, and it's a good plan to identify these overprescribers. My question, and I don't know if you mentioned this, is the death certificate must state on the death certificate that there is an opiate overdose or opiate-related death. So sometimes that doesn't appear on the death certificate. Now there are some areas or some counties where the coroner is not the MD. It is a sheriff and we tried to get a bill passed and I don't know what happened with that. So you might find that it's hidden. So there's no way of really extracting that information.
Yeah, I would agree that this isn't going to capture every single death that occurs related to a prescription drug. If it's not on the death certificate, we're not going to find that.
So it'd have to say somewhere on the list of causes, opioid dependency, opioid-related
overdose,
death, somewhere in that.
There's actually, I don't have the list in front of me, but there's several different categories that they categorize the death from, and we hit all of the ones that were drug-related.
And I wonder what kind of, educational process for, county coroners we could provide about this program that would encourage them to report correctly. But what are your thoughts about?
I think that is a great idea. Actually, in September, I am actually speaking to the Coroners Association, so perfect timing.
Okay, good. Then you answered my question. Thank you.
Judge?
I have just one question, being a non-medical person. But if there is an unexplained death and a physician cannot sign the death certificate such that an autopsy or further investigation is required by law, I believe, and please correct me if I'm mistaken, that an office a county that doesn't have a medical examiner's office, their sheriff must use a medical examiner to conduct the autopsy.
So there was a bill passed last year. I'd make sure that required the pathologist to be the individual that's doing it to be a licensed medical physician. So that passed. Prior to that, that was a gray area, and that's why they put that bill in. I can't remember the senator's name. Hannah Beth Jackson actually put the bill in out of the county that they had some issues down there with an individual, and it was a gray area as far as whether the individual actually performing the function had to be a licensee or not. And Dr. Lewis is correct. There were individuals in the sheriff's office and others that were performing duties that to us would have been a violation of the law, but because the law was gray, we needed the change to make it very clear that the person had to be an MD.
And how far back in time can you go regarding
so that is a problem
certificate
that we're actually even running into here. Because of our statute of limitations, we can only go back 7 years. Because and actually we can probably only go back 6 years to be generous to our investigators, because we have to file the accusation within 7 years of the incident, not within us, just opening the case. It's actually, we have to fully investigate it and take action and file that accusation within 7 years. The other thing is the length of time it takes us to even get the information and look at it. This is 2012, 2013 data. We're already looking at, 2 years out only for the statute. The other problem we have is we need to move on these cases too, even though there's such a huge volume and everything, because we also have to file that accusation 3 years from the date we know about it. So once we have that expert that actually has identified this as an individual that may be inappropriately prescribing, then our 3 years starts ticking at that point too.
Dr. Levine?
Whichever one's shorter.
Well, let me just ask this again. If, in fact, a death certificate is received that a medical person, a medical doctor, has indicated that the cause of death is an opioid overdose, isn't that relatively simple to investigate in terms of going to cures or getting the patient's medical records because the determination has already been made by a medical doctor?
We still have to, that basically is a tool, a pathway for us to go. We still have to then get the medical records, which in this case, at least the law is on our side for us, other than in other cases where we'd actually have to have, if the individual, it was a patient who was still alive, we actually have to have them sign off on the on the release of information. In this regard, the law was actually changed a couple years back, maybe even in the last 2 years, that states that if the individual has passed away, we have to make a good effort to contact the family, basically the next of kin on the death certificate. If we don't hear back from them, then we can write and request the records from the physician. Now, they can still say, we aren't going to give you the records, and then we have to issue a subpoena, and if they still won't, then we have to go through an enforcement subpoena. But we still have to get all of those records. Once we get those records, we still have to send it to an expert who can opine as to whether there was a violation or not, and then it will go forward for an accusation. So there's still that process that has to be followed. So it's the overprescribing cases that we see here. A lot of times we hear those are difficult cases sometimes to get into because just the volume, I think, of evidence that you have before you too.
Thank you.
Dr. Levine?
So I just want to understand the data that you presented, and it's very useful. So 2,692 deaths in which the use of an opioid was associated, either a finding on autopsy, but
right.
Of those, 2,256 had a cures report. Does that mean that the 440 gap might have been diversion or using somebody else's drugs?
Yes, they did not have a hit on the cures when we ran that patient. And that could be, too, because it might have been a heroin overdose.
Heroin or out of state or
yeah, yes,
sibling. Okay.
Right. Mm-hmm.
And of those, it looks like about a total of 20% of the deaths had a prescriber whose picture was at least worth 1 out of 5 worthy of investigation.
Right, somebody involved in the process, yes.
And then my only other question is Cures 2 capable of querying by dose? So is there a way of querying cures for prescriptions greater than X, either total milligrams of oxycodone or MMEs if you're able to convert it?
They can do MMEs definitely, because right now they send individuals there's 5 different warning signs that they send individuals, physicians who are signed into cures, and one of those is actually the MED for their patient. So I know they can do that. If we could actually run a report that looks at how many MEDs, I don't know that I can ask. I don't know. I can't answer that question.
You could run a report on any prescription that was greater, 80, give yourself some margin, so 100 or 120 MMEs per day.
We can do that.
It would give you another window into. Now, some of these may be hospice patients. This doesn't mean they're all a problem, but it would give you another window into the prescribing.
Yes. Okay.
Dr. Bowles?
I was just going to say that's exactly my question, because I think that will be so important to get that cures big data report. I think that'll be very enlightening. And, I agree with you, Dr. Levine, if you did a 120 MMEs, that would probably be, that's definitely a high dose of opioids.
Yeah. Okay. I'll put one in for
Kim.
Yes.
Am I correct? You mentioned you have 526 cases need to be investigated, right? How many expert or medical consultants involved in reviewing those cases? There's a lot of volunteering.
Yeah, that for the 520, once they go out to the experts, it'll be our whole pool basically using as many individuals as we can. I think the upfront, when we had them all reviewed, which is why it took a while, I think they only had about 5 individuals who were actually reviewing them to say, okay, this individual actually needs to be investigated. But our 520 is going to go to our normal consultant pool, whether it's either in the field, under HQIU, those experts in our expert reviewer program, or if it's in our central complaint unit. So there's definitely a need for experts in pain management.
It seems a big manpower need just to process that years alone.
Well, it's not only just for the experts, but this is a huge number to be putting into an already stressed investigative unit, as well as into our central complaint unit. So a lot of times our cases like this would go directly to the field, but our individual, I met with Miss Nichols, and we decided that because we can get these records pretty easily, if we go through the process of contacting the next of kin, we have that next of kin information, and then we can go ahead and send a letter to the doctor that says we've done this and now you need to provide us the records, that we're actually working those in our central complaint unit unless there's actually a case out in the field, like maybe we have one on overprescribing that we can consolidate it into, or unless the individual has an accusation or something like that hasn't gone too far in the process. So this really is, right now we've taken them from the field and they're actually being worked in our complaint unit.
Are those experts like internists only, or they need to have training in the pain management?
For these, we would need to have well, it depends on the physician, because remember the board voted that whatever the specialty of the physician was what we would have the individual doing the review. So if this was a family practice physician, we're going to have a family practice doctor review it. If it's an oncologist, that's a bad example, but an individual in gastroenterology, we're going to have somebody in that specialty. Cardiology, the cardiologist. So but a lot of these could be pain management doctors where we would send them to a pain management expert.
Thank you. Any public comments from the audience? I think we have one. Mr. Feldman.
Good afternoon, Dr. Yip and members. Julie D'Angelo, Felmouth from the Center for Public Interest Law. I think nobody would disagree here that this information is extraordinarily important for the medical board to have, and it should not be denied that information for no good reason. Yet that is what happened when the governor vetoed SB 62 a few years ago, and a lot of us were very disappointed in that veto, including this board and its staff, because you worked very hard to get that reporting requirement to be easy. So I just want to thank you and your staff, Ms. Kirkmeyer and your staff, for pursuing this. Because it is so important for you to have this information. People are dying all over the country due to this prescription drug overdose epidemic. And I want to thank you for pursuing this issue and thinking outside the box. Thank you.
We have to give a shout out to Miss Mason at Senate BMP too for that.
Thank you. Any comments on the phone? Yeah, I think the board you would have our support to allocate resources for that. I think this is a big issue that we really need a lot of manpower in all angles. Thank you.
Yeah, the best thing is that we can use this to build a future budget change proposal for staff exactly for this project. So
that's huge. Thank you.
Yes, I have one quick question. Goes back to, I think, what Judge Feinstein asked. We have a process where first of all, we have a cures report, and it'll say Dr. X prescribed this and we know who the patient is, it's their report. And what is the purpose? Let's say if you were to get the medical record. In other words, you've got another step in there to grab that medical record, so that if you see what I'll call a positive cures report, does a letter go to the physician saying, we've looked at your prescribing habits and we're going to be sending you this, so that, in other words, somebody needs to be anticipating that? Because getting medical records, we all know, takes a long time.
No, as soon as we find out that this individual is somebody that needs investigated, we immediately send the letter to him asking for those medical records. Well, once we've reached out to try to get the authorization. So send out the authorization to the next of kin. If they come back and they say nothing, then we send them a letter immediately to the physician.
That's linked to someone that's passed away, who's died.
Yes.
I'm talking about another direction if you have big data sets and you know that there's a problem.
So we've talked about this a little bit. It's almost like other states who've done like a report card for doctors. This board, I don't know that we want to go down that path quite yet, but I think that that's something that in time, I think with Cures actually giving them already the information through the 5 warning signs, maybe that's something we put on an agenda, whether you believe that if we run Cures and we find, rather than being more proactive in regard to that. I know this has come up from the UCD, you know how we did the Cures survey and we assisted UCD. One thing they wanted to do is to do like, okay, as we find information on physicians, we want to, you know, maybe the medical board could send a letter to them that says, hey, it looks like you're prescribing a lot of opioids. It's something you want to take into consideration. You know, here's our guidelines, here's our information. Maybe that's something you want to bring to this committee. I don't know. I'd have to hear from you.
Yeah, I had is that okay?
Please.
Yeah, and I guess mine was along similar lines, but, you know, backing up one step from death, which is hospital admissions and ED admissions with opioid based overdose, with the code that are coded for overdoses. Beginning to think about, so how would that be a source of information to look at? Yet another layer, and then because that it's not quite the entire prescriber population that you're trying to communicate with, but it's looking at sentinel events, basically somebody who's admitted with an overdose, trying to connect the Cures report for a prescriber.
And actually, CDPH does gather that information because they have heat maps out on their website where you can go and actually look at, you know, for Yolo County, how many individuals did they actually have that went to the ER visits regarding opioids overdose. So they actually already have that out on their map. I'll send you all a link to their webpage where it has the heat map information. So I think that's what you're talking about because it's captured. They capture that information actually.
No, I guess my question is how that would translate into inquiry by the medical board.
Right. No, yeah. No, I know that. I'm just saying they do. I know they do capture that. So it might be something that we can actually ask them for to see if that's another avenue for us to identify individuals before we get to the point of it's a death certificate.
Because they're not running Cures reports, CDPH.
No, they're just gathering the information and posting it. So yeah, definitely another avenue to seek with them.
Right. I think the consensus we need to make use of the statistics available to do something before we see a death certificate.
Right.
That make more value than seeing a death certificate. Thank you. Let's move on to agenda item 8. Ms. Kursmeyer again, please. On the prison and the enforcement statistics. Please.
Just one other point before we close. It should be noted also that California is one of the states with among the lowest incidence of deaths per 100,000 people in the country from opioids, which suggests we're doing something right as a state, even though we're hardly perfect and there's a lot of opportunity to improve.
We need to do more.
Right.
Thank you. Ms. Kursmeyer, agenda item 8, presentation and enforcement statistics.
Okay. Thank you. So first of all, I want to point out that the statistics that I'm going to be providing to you, these are not performance measure statistics. These are something that was a crazy idea when I was sitting in the last enforcement committee meeting based on some of the comments from the members. So the performance statistics for enforcement are actually also in 20B of the full board packet. So if you want to talk about the length of time and the statistics that we shared with Dr. Yip, those are actually in 20B. So I'll direct your information information there, but this was actually something from the last enforcement committee meeting. There was discussion about obtaining statewide enforcement statistics. And around that same time, I had also been reviewing heat maps from the California Department of Public Health that they were putting on prescribing an opioid-related deaths in the state, kind of similar to what we were talking about earlier. After the meeting, I actually met with Sean Eichelkraut, the board's information systems branch manager, to discuss what reports would be possible. So on pages ENF 8-1 to ENF 8-9 are pages of some samples. I'm going to stress that word, sample reports that we have put together. I'm going to walk you through each one. So the first one that's on 8-1, this is actually the first report, and it identifies complaints received per 10,000 individuals in each county. So if you're looking at the map, the color of the counties themselves is based strictly on the population per census information. Okay, so that you can see the heavy counties and how that relates. Then the color in the counties themselves, so that circle, that actually relates to the number of complaints received per 10,000 individuals in that county. And again, it's the county information, it's based on the complainant's address, or if there was no address, then it would be by the physician's address of record. So this is based on how many complaints we received in each county by the complainant's address for each different county. So does that make sense? You see what we're looking at? Okay, all right, so that one's kind of an easier one. So that's the first map. Okay, and then the subsequent following pages are actually the maps basically put into data charts. Okay, so if you look at the next page, you'll see that. But then it also added, I also wanted to add the number of licensees per county based upon their address of record, just so you could see how many individuals are actually in each of those counties. And one thing to remember is when we're identifying aggregate information like this, because we do have some of the counties who have small numbers of physicians, we don't want to, make sure we can identify any physician when we're looking at complaint information. So that's really why we went with complainant information, and why you'll see some of these are based on more complainant information. Okay, then on ENF 8-4 is a sample of what a map would look like for information based upon the medical service. So this is actually captured based upon the allegations involved and the type of practice the allegation fits into. There are several other types. We just chose the largest one to give you a sample of the map. This is not based upon the physician's specialty or board certification. So remember, this is based on the procedure itself and what was performed. And this is based upon our staff's review of the complaint. And then again, following that, the pages are, again, the statistical information. So if you're looking at this one, again, the county colors underneath are, again, based on just the population. But then in each circle, you'll see that's how many came in for a procedure related to either general medicine or family practice in those areas. Okay. Then moving on to 8-7, now we're looking at sample information that can be obtained by the allegation. So again, we chose the largest one, which is gross negligence and incompetence. So again, same thing. It's information for the counties is by the population, and then the little circles and the colors, those are based on how many complaints regarding gross negligence and incompetence we get per 10,000 individuals. So this is just a sample of information that we can put together based on the statistics that we can pull from our databases to provide to you. And what we were thinking is if we can get information like this, it might be something that we can actually put on our website for individuals that could go out if they're curious or interested in this. I mean, reporters may also want this information, and then we could actually build those maps out there. The other thing that we're going to look at too is building a map like this based on disciplinary action per capita per county, so we could look at that as well. We just don't have that one built yet. So this is kind of a sample. I'm really looking for suggestions from the members, anything else you would like to see, or if these are even helpful, if this is something you think, yeah, it's nice, it's pretty, but it doesn't really give us a lot of information, we can take it back to and look at other information. But
Dr. Lewis?
I just want to be careful that this is not misinterpreted by the public, and you really educate them how to read it, because you're explaining it now, and was kind of getting it. But if I look at Amador County, I'm thinking, oh my God, Amador County, it's just always at the top of the list there. And I think you have to be careful about putting all this information out there too much, everybody, unless you really instruct them how to read it. So that's just my little concern, that it's going to be misinterpreted or taken by a reporter off
And
into
it's
left
something
field.
definitely we can put, little categories and explain it. I actually think, just in my review of complaints, and I know that Amador really is struggling actually with the issues of the overprescribing. I kind of wonder if some of these complaints, and the reason they are so high actually is because of the issue that's going on in Amador County with the overprescribing issue. Because they would kind of fit into gross negligence and incompetence unless they were actually characterized as overprescribing cases, but they could be in there. So when I saw the Amador County, I was wondering if that had something to do with it. I can't base that on anything, but it's just interesting to me.
Dr. Levine?
These are the maps are three-dimensional because you've got three different variables, and I think that adds a level of complexity that's a bit challenging. I mean, one way to deal with it, if you're going to post it, is to have it done as a series of overlays.
Okay.
So the first visual you see is the population, and then the size of the circle, and and being able to correlate the size and color of the circle. Yeah, I mean, I'm already gotten confused. So
the size of the circle and the color are pretty much the same.
Same, right?
Yeah,
but
it's just how small or how big they are.
But then the next dimension is the number of
the actual number itself.
The total number,
right?
Exactly, and then the number of physicians, because they're one of the challenges in some of these underserved communities is you've got beleaguered physicians, unable to say no in the face of great need, and you may inadvertently misrepresent intention, if you will. Right. So I do think the qualifications on interpretation of the data have to be very clear. And I'm no visual graphic designer, but designing this in a way that makes clear what the limitations of the data are, and at the same time represents accurately and graphically the size of the challenge.
And I know at the last meeting, when you all were talking about it, you were looking at the specialty of the physician. You kind of wanted some information on the specialty of the physician, and Dr. Balat and I actually talked earlier about this. That one's a difficult one because we have such a large number of individuals who have not reported to the board. We have, I want to say it's between 25 and 30% of individuals that do not complete that portion of the survey where we don't have that information. So to me, it would be not good to put out information that has such a high unknown with it.
I personally think the effort to produce this is admirable.
Yeah.
Really, this is a good start.
This is our IT staff. And again,
yeah.
It's if you think they're useful, we'll go and we'll work more on them. I just, after the last discussions and you were all asking for information on, hey, I'd like to see in the state where the complaints are coming in and how it's looking at, this is kind of the best way that they kind of thought we could portray this information. So,
and one interesting thing is the big dark blue thing is Los Angeles.
You can't see it copied very well.
I can't read the fine print.
Yes.
San Bernardino.
And San Bernardino, right. And then there's also Riverside and San Diego. Those are the large ones. And once you get down to that high blue color or the high number population-wise, it's hard to differentiate the difference, but they're all kind of in those overpopulated areas.
Right, and what it does is it makes it appear like there's no problem there.
Right. It's kind of like actually how California does so well on the opioid issue. Right. It's because we're so populous. Yeah. Mm-hmm.
I think it's great work, though. Any public comments from those in the audience? Dr. Hawkins?
It may be presented later, but do we have statistics on physician participation in the CURES program?
I'm sorry, Dr. Hawkins, I was worried about a quorum issue. Did you ask for statistics on cures?
Physician participation in CURES.
I do. Hold on. It's actually in my report on 20A. So as of June 15th, and actually I have the July information. I'll remember it in just a minute. So we had, as of July 15th, there were 91,407 physicians registered in CURES. Is that the information that you want?
Wow.
Yeah, so from remember 6% to, so mandatory does help. And actually this was, we have, it might be up to like 91,600. There was just a couple hundred, I think, jump between June and July. And again, I don't know if we're ever going to get to the point where we can actually identify those that aren't there that have a DEA. That's what we're struggling with, is finding out who has a DEA and is required. So.
Right. Thank you. Are there any comments from those on the phone?
Michelle had a comment.
Oh.
I just
No
have
comments
one
from the phone
Dr.
at this
Bola,
time.
No. Okay. Also on the map, we had talked about this earlier. So when I first looked at this as a family physician, it said medical service, family practice / general medicine GP. What I understood, and this is what I want to clarify, it's not real. This is not the specialty.
It is not.
So I would wonder if it's the medical service. What I understood is when you get the complaint, it is based upon where something may occur. Well, the type of service. It's
The
general
type of
medical.
service.
The type
Right.
of service. So it's general medical. So I would just be sensitive to that. Thank you.
Yeah, and we'd have to make sure that we really clarify that this is not the specialty of the physician. This is what the procedure was, because as you all know, we could have a individual who practices OB-GYN who's actually doing a cosmetic surgery. So it's going to be listed as cosmetic surgery, but the individual's actually trained as an OB-GYN. So.
Thank you. Moving on to agenda item 9, future agenda items. Any members have agenda items for the next enforcement committee meeting?
I have
Dr.
one,
Bola?
and I'm not sure, and this is how I don't know about this, and I don't know if it's who regulates. I wanted to look at, are we able to look at this data for people that are in workers' compensation? Like that group out, so that would be what I would like to know. Ms. Kirchmeier may know that. The question is, just as we're looking at these, I just got done saying about the specialty, but are we able to gather information on the physicians that are involved in workers' compensation?
No, we don't gather that information, and it's not asked on the survey either. We ask for administration. Are you doing administration? We ask for telehealth and then how many hours in patient care, but there's nothing on there. We would have no way by looking at a physician if they're workers' comp or not. Does that answer it?
It does, but I think it's an interesting question. I think I'll talk about it later,
Okay.
where and how we look at that subset of doctors.
Yeah, the only way we would be able to get that information is if the Division of Workers' Comp would provide us a database of their physicians that they have that can work for them.
Thank you.
Thank you. Are there any public comments from those in the audience on future agenda items? Any comments from those on the phone for future agenda items?
Catherine, do we have any comments on the line?
No comments at this time.
Thank you. We'll now move on agenda item 9, adjournment. Meeting adjourned. Thank you.
Well, good afternoon.